Hello, I'm Dick Corsell, and welcome to Community Care Network Connections. Connections is a show to inform the viewers in the Rutland region of Community Care Network and its agencies, Rutland Mental Health Services and Rutland Community Programs. Today, the focus is on Rutland Mental Health Services and specifically emergency crisis services. On town meeting day, many residents in Rutland County will be asked on their town meeting ballots to support Rutland Mental Health Services, and that support goes for emergency mental health services. So today, our guests are Michael O'Brien, who is the Director of Emergency Services for Rutland Mental Health Services. Michael, welcome.
Thank you.
Dan Quinn is the President and Chief Executive Officer of Community Care Network. Welcome, Dan.
Thanks, Dick.
And Curtis Taylor is an emergency clinician for Rutland Mental Health Services. Welcome, Curtis.
Thank you.
Today we're going to talk about mental health services. And Dan, before we get into that topic specifically, if you could tell our audience a little bit more about Community Care Network and specifically Rutland Mental Health Services. Many or may not be familiar with what Community Care Network is.
Sure. Community Care Network is really two organizations. One is Rutland Mental Health Services that many know, and the other that many don't know as well is Rutland Community Programs. And Community Care Network is simply the umbrella name for those organizations. Rutland Mental Health Services is really a bunch of different programs. It's a very large organization. About half of what we do is really developmental services. For folks that aren't familiar with that term, it refers to people with conditions like Down syndrome or Rett syndrome and Angelman syndrome. Those are folks that really need a lot of care, frequently 24 hours a day, and we provide them their services. Outside of that program is all our mental health and substance abuse services, which is where Michael's program resides. Our substance abuse services are on Granger Street. And in the mental health arena, we have a number of programs. We have one program that's just dedicated to those with severe and persistent mental illness, folks who've been in the hospital many times and really require a great deal of service to lead a life in the community. And we like to think that we provide them help them achieve as meaningful a life as possible. As well, we provide adult outpatient services, a lot of services for children and families as well, and then certainly our crisis services that we're here to focus on today.
Good, thank you. Mike, what is a mental health crisis? And that is the topic of today's show. But what is that, and how's that different from the troubles that we all experience occasionally?
Well, that's a good question. We tend to let people decide for themselves what a crisis is when they contact us. We don't try to predefine it in any way because we want people who are having a difficult time to contact us. But generally we think of a crisis as a situation in which an individual or person may have a very stressful thing happening in their life, and their normal ability to cope with that for whatever reason is not as good as they might need, and so they need some extra help. So usually it's someone who's having a very difficult emotional time, though it could be someone with a substance abuse problem too, who is struggling and wanting some help. And we get contacted either through our 24-hour hotline number or directly in a face-to-face encounter, either in the emergency room or at our mental health center.
Okay. If you could just elaborate a little bit more for the viewers, when we talk about crises and the self-defined crises, as you had mentioned, allowing an individual to decide whether or not something rises to the level of a mental health crisis that would require that type of intervention. What are some of the types of crises that people in the Rutland area would necessarily encounter that would have them reach out to you for assistance?
Well, you know, clearly a lot of people that we hear from are people that have some type of mental health problem or mental illness, and they may be struggling with that. And you know, there's lots of different types of mental health problems that people can have. For instance, someone with depression who may be feeling that life is not worth living anymore. We may get a call or see someone like that. It could be someone who has experienced a number of losses. For instance, they might have lost their job, or someone in their family might have passed away. And their ability to cope with that has been challenged, and they maybe need someone to talk to, or some people may actually need to be in the hospital, and so they contact us, and we can help them with those kind of things.
Okay. Dan, let me ask you, as the CEO for Community Care Network and Rutland Mental Health Services, why is it the mental health agency, Rutland Mental Health Services, that is providing these emergency services as opposed to, for example, a hospital that you would traditionally associate with emergency care?
Sure. Well, really, many states use the same system that we have here in Vermont. Really, the Department of Mental Health determined that the best way to provide these services throughout the state was to have the community mental health centers, like Rutland Mental Health Services, provide these services frequently in the emergency department and at other times actually in other community settings. A benefit of doing that is the people providing the emergency crisis service have a very intimate knowledge of all the community services available. Many people who access the emergency department do not end up going to the hospital. Some do. But really the vast majority end up going back to the community with some sort of community support. And since we're so intimately involved in that, many states and Vermont have determined that the best way to have that done is through the community mental health centers.
So this is something that the state of Vermont has decided
Yes.
is the most efficient, effective, cost-effective way of delivering
That's right.
emergency mental health services.
Mhm.
Let me ask you, Mike, directing this program, how busy is a crisis team? How many people do you have on the crisis team? How busy is it? And what are some statistics about the number of people that perhaps you see in any given year?
Well, I'm sad to
period?
say that we've been very busy lately. The last 6 months or so, we've seen a real uptick in people requesting services. For last year, we saw almost 1,200 people in crisis, and that's a 17% increase from the year before. So we're seeing kind of what everybody is feeling in the community, that there's more stress and tension, I think, as a result of some of the economics that play into it. Right now we have 6 people working on the crisis team besides myself, with a total number of, I just figured it out before I came over here, about 52 years of experience working in crisis. So we have a well-seasoned staff who have a variety of credentials. Most of them are master's credentialed staff, some that are certified alcohol counselors and licensed social workers. And so they provide those services with a real in-depth clinical experience and knowledge about a variety of mental health and substance abuse issues, so that when people come to us, they're going to be seeing someone who's been well trained.
Good. Let's talk about how someone accesses the mental health. And we'll be talking with Curtis in a minute in terms of what the process sort of looks like. But how do people get help during a mental health crisis? Somebody, let's say a family member or a friend, is experiencing what you would consider to be a mental health crisis, and you feel that that person should get some help. How does this all start? How does it begin? Who do you call? Where do you go?
Well, you know, it's really important that people feel that they have access and they feel comfortable in calling. So we want to make it easy as possible for people who may have never thought about contacting our crisis team. We do have a number, 775-1000. That's fairly easy to remember. And we encourage people who are having a difficult time to give us a call should they need to do that. Sometimes people will call us anonymously. They won't even give us their name, and that's fine. Anything that we can do to encourage people to contact us when they're needing help, we want them to do that. So there's the phone, and that's the easiest way for people to contact us. They can also come during business hours to our 78 South Main Street office, where people walk in and we will see people who are having a crisis. And we also see people in the emergency room and in the community as well. You know, with 6 staff, we have a limited ability to go everywhere where crisis might be needed, but we do the best that we can to cover that. And so we sometimes also don't hear from the individual who's having a crisis. Sometimes, as you mentioned, we might hear from a family member or a friend who's concerned. And sometimes people call us just for information. It may not be that we do anything other than give them some feedback and support on how they can help their family member. Like we might suggest that they bring the family member to the emergency room or to our mental health center. And we can provide them with some help and guidance if they find themselves in a situation that they don't know how to handle. And so we strongly encourage people to do that.
How do you interface with other community resources, for example, law enforcement or other social service providers that may be in contact with people that they may be able to identify early on as perhaps needing assistance in mental health?
That's really important. As Dan mentioned earlier, a lot of the people that we see do not end up in the hospital. And so people like Curtis have to have an in-depth knowledge and relationship with service providers in the community. And so when we do see people, we do an assessment to kind of understand what is going on with the person. But then the second important part is that we need to help people get to where they need to be, and that may be to refer them to someone in the community for weekly counseling. It may be to refer them to our partial hospitalization program, which is an intensive 5-day-a-week program. So we have to have a really good knowledge and relationship with providers in the community. We do work with the police closely at times, and sometimes we get called upon if there are individuals in the community who are having a very difficult time with a mental health problem and may be at risk of harm. We'll be working with the police to try to get that person screened to determine that, you know, that they're going to be safe. And so we work closely with them around things like that.
Dan, as the business guy here, could you explain a little bit how emergency mental health services are paid for? How does that all work?
Well, the vast majority of the funding comes from the state of Vermont via Medicaid. So that is most of the funding. Of course, we bill private insurance companies as well. There are some contracts that assist in paying for some of the services. And certainly the town giving that we've received in the past is very, very helpful. As Michael mentioned, particularly with increasing demands, significantly increasing demands, just 17% increase in the last year. And really, we've been getting reductions in funding for the last couple of years due to the national economic downturn. It's really all the more important that we try to maintain funding streams to keep this service going.
Good. Curtis, let's talk about your experiences as an emergency mental health clinician. And could you give an example, obviously maintaining confidentiality, of course, of somebody that perhaps recently was seen by the crisis team and the professional help they received? What was that experience like, kind of sharing some of these personal stories?
I had recalled one person that the team had seen recently, and this person had been brought into the emergency department at the hospital by law enforcement, and this person was psychotic, dangerous to themselves and to others. Lots of hallucinations were being reported by this client, and that client had been medically cleared by the physicians at the emergency department. We had seen this person, and this person needed treatment and didn't realize the depth of the need, and that person was held on an involuntary commitment. It was a short stay. Person turned around, expressed gratitude after a couple days of an inpatient stay, and Next time we saw this person, very similar presentation, which was pretty unusual, and it was nothing about being off medications. There was a lot of contact with the community providers that we knew who to call, what information to look for, and it was a completely different reason for the same presentation, but the disposition, that person went home within about an hour of being in the emergency room. So we had to tickle out each time what the precipitating factors, what had gone on before, to make an informed decision about the person's safety. So it can vary from person to person. Obviously, it can vary from one individual presenting a number of times. But we had found that safety and using the least restrictive methods of care were always prime. That was always the intent, is to get people safe, make sure they're safe, have collateral contacts with family, primary care physicians, anybody else who's involved, to make sure that we are using the least restrictive setting for adequate treatment.
Good. We'll follow up, and Mike, what you had said before, and actually what Curtis had just referred to. What happens after they've seen a crisis counselor? What type of follow-up is there? You just described a situation where there was a client that you were closely monitoring, and the next time this client presented themselves, you had to assess quickly what may have changed from the initial event that brought them to the emergency room. What happens next? What's the usual course of
Well,
treatment?
you know, one of the things that we do is we often consult with a psychiatrist in the emergency room. We have several psychiatrists that work with us. And so we're not in there by ourselves, and as Curtis, I think, was alluding to, we work with teams of individuals. So Curtis was in the emergency room, worked with a physician in the emergency room, also consulting with a psychiatrist, and sometimes I get involved. And so there's a team of people working together to try to steer the people that we see in a direction in which, you know, primarily we look for crisis stabilization. I mean, our job at the time, if someone's in a crisis, is to work towards stabilizing that individual so that they can get further care if they need it. And sometimes we just provide them with information. If someone is, we see a lot of people with substance abuse problems, sometimes people who have an alcohol dependency can be clean and sober for years and then fall off the wagon and need to get some help. We can give them a listing of all the AA meetings in the area, and that may be enough for them. Other people may require more intensive treatment, such as hospitalization, or go into residential substance abuse treatment. We help people get connected with those. But we also more often connect people with the services that are available in their own community. And we have a list of probably 40 or 50 area providers that provide different types of treatment. And we have information on what insurance they take and so on, so we can steer people in the direction of getting individual counseling if that's what they need. People don't always follow up. People aren't always able to follow up. And so sometimes we'll see people repeatedly, and that's what it sometimes takes for people to get the kind of the help that they need.
So it's a high-touch approach. Obviously, there's a lot of follow-through, a lot of integrated systems, the whole system of care you're networked into.
Well, you know, in some sense, it's a fractured system of care because we have all individual providers. It's not a unified system of care. And though we do what we can to bridge those gaps to get people where they need to be, I think that it could be improved, our total system of care. And we always are coming up against resource limitations. There are services that people need in our community that aren't available, and that becomes a real challenge for us. For instance, getting psychiatric medication is a big challenge right now. We have primary care physicians, some of whom are comfortable in prescribing that. Many of them are not. And there are 2 psychiatrists in the community who do see people, but that's a very limited amount. And so we experience the challenge every day of not having enough resources that people aren't able to access. And for our community, a very important piece is that the crisis team is the safety net for our community. We're the place where we catch people before they fall and try to get them where they need to be. So it's a very critical service for our community and the people in Rutland.
You talked, Mike, about the substance abuse, and Curtis, you mentioned that as well. How big a problem is that, and how is that handled from an emergency standpoint?
When people come to the emergency department at the hospital for depression or other mental health issues like that, we always ask about substance use. The doctors will often do screenings for substances. They will often do breathalyzers as needed, but we're finding a very high percentage of people that we see use something somewhere along the way. It may be recreational, it may be once in a while, it may be underreported as to how much is being used. We need to ferret out what is an accurate account of the use, because that will always shade or shadow the clinical picture of what might be going on underneath that. I would say sometimes we're seeing maybe 75% of the adults that we see have some sort of substance use. I don't think that's overestimated. I think that's pretty close.
It's certainly a disturbing statistic, and it's certainly a testament to the work and the importance of the work that the crisis team does.
Yeah.
To that level. Dan, I do want to now ask you in terms of funding for these types of services and for mental health services in general. You mentioned obviously the economic distress of the past few years has certainly filtered its way down into the states, and funding is limited. But what's the effect of underfunding mental health services and crisis services? I mean, especially in this region where we're hearing that there is such a need and such an increased demand for these services.
Well, I guess the best way I can try to describe it, I mean, in addition to being an administrator, I'm a clinical social worker by trade, and I actually used to do a lot of emergency department work and crisis work. If people are familiar with, if you had a medical problem and needed to go to the emergency department, you're familiar with how busy a place it is. And everybody is familiar with frequently there are long waits, and there's always lots of work to be done and to try to get that down. For the mental health and substance abuse problems we see, it's just as busy. We are statewide seeing longer and longer waits. We used to be able to have people in and out in hours, and that was routine. We now have people in different parts of the state, sometimes in that emergency department for days, sometimes here in Rutland overnight. The volume of people we're seeing is ever increasing. The funding is actually going down. The stress on our staff is significant. They're doing yeoman's work and an excellent job, but it makes for a very, very difficult environment. And it adds more stress to the people that we are serving in that setting, and that's the last thing they need. So it does make it very, very difficult.
What would happen if there weren't these services available? What would happen if there were no mental health crisis services offered by Community Care Network and Rutland Mental Health Services in the Rutland community?
And I think they're so important. It's why they're virtually anywhere in this country you'll find them, because to be without them you would have to rely on what I guess we would refer to as the other first responders. We're really first responders in a way. So without the mental health crisis team, people would be falling back on, well, I guess, firemen and policemen, and if the people didn't have this place to go to, they would call on the other first responders in the community, and they would be overwhelmed and untrained and unable to really meet this need. It's something that a community simply cannot go without.
In our last brief moments together, anything that you would like to add, Mike, in terms of the importance of this service, and anything that perhaps you would like the viewers to take away from this conversation?
Just remind them that our number is 775-1000. That's the 24-hour crisis line, and someone's there 24 hours a day, and that's important to have. Even if you don't need it right now, it's good to keep that, so at some point, if it's needed, it's available. And you can contact the Mental Health Center if you have any further questions, and we can be reached at 775-2381. And that's about it.
Great. Mike O'Brien, Dan Quinn, Curtis Taylor, I want to thank you for joining us on Community Care Network Connections. If you would like to learn more about Community Care Network, the web address is www.rmhsccn.org. I'm Dick Corsell. We'll join you again on Community Care Network Connections.